Good evening. So nice to see all of you here and welcome you to the third in a series of sessions on mortality as medicine. And area code 909 is calling me. I'm going to ignore that. So welcome, and it's my pleasure to introduce to you Dr. Eric DeJonge. And Eric and I have a history together. So I was just telling Jim and Edie Garrett at dinner that Eric and I married best friends. So our spouses met each other. You said the 7th grade. I was thinking it was in the 9th grade, but it's 7th? Okay. In a typing class, right? Back when, remember when people took typing? Yeah. So we're the beneficiary of typing because our wives met each other, and there were some fairly significant hoops that we each had to jump through in order first to be invited to be the significant other of our wives, but then we had to be invited into this other circle so that I got to sort of keep hanging out with Eric and Melissa after Sarah and I married. All this is significant. If you want to hear the real down and dirty details, I'll tell you. Getting closer to today, Eric and Melissa's wedding was my very first wedding, and we were just figuring out, I wasn't even ordained. We think that it took, I mean, it did take as a marriage, right, it's going well. And I think someone actually signed off on it. There was a real minister in the room, and he signed off on it. So that was kind of the next piece. We raised our children together. We shared a babysitter. So my daughter really thinks of Eric and Melissa's kids as her siblings. So all that wonderful intimacy. Along that way, I became a priest. Eric became a geriatrician, trained in college at Stanford and then medical school at Yale, and ended up doing a residency in geriatrics here at Hopkins. And then has spent his career at the Washington Hospital Center creating a geriatric, along with his colleague, creating a geriatric house call program. And we're getting to live our lives beside each other, which is pretty amazing, the best gift of all, really. So thank you for coming and being with us and for sharing your professional self. Eric also really likes politics, so if you all want to, go into that, just saying, there are any number of things you might want to ask him, and I encourage all of that. So, Eric.
All right. Thank you, David. Can you all hear me okay? Okay. So, I'll tell a little bit of my story that David, before I met David. I grew up in north side of Chicago, and I kind of bounced around the country through my training, and I landed in Baltimore in 1992 at Johns Hopkins Bayview, where I was a primary care internal medicine resident, worked there for a couple years, did a health policy fellowship at Georgetown, because I am interested in politics, even to this day, I am. And then I came back to do geriatrics training in a fellowship at Hopkins Bayview, and that's where I met kind of people who were my role models for what has become my career, the geriatricians at the geriatric center there. And I made my kind of first house call in Highlandtown in Dundalk. My boss, his name was Dr. John Burton, who was a wonderful mentor and kind of father of a lot of geriatrics in Baltimore City, said, these are your 8 patients. You're going to make house calls to them like after your 36-hour shift. And back then, residents were still doing 36-hour shifts. And I took care of these people in Highlandtown and Dundalk, and I kind of found a whole different level of being a physician and knowledge and understanding of patients and their families. So that led me, actually, I happened to be at Bayview on the second floor, and this medical student was assigned to my team. I was a second-year resident. The medical student was named Melissa Turner. And we worked together. I was her teacher for a month. And then it turns out she became my wife. And she then trained at Johns Hopkins downtown internal medicine, and then we moved to D.C. in 1999. And I met Dr. George Tyler, who came to the talk tonight. He surprised me. He's in the rocking chair back there. And George and I met. We had a beer at the Inner Harbor, and we decided, on George's kind of inspiration, because he's been a house call doc for 40 plus years, to go to D.C. and set up a house call program in D.C. and serve the people who are the most vulnerable, underserved population, who have trouble getting to the doctor's office, and take care of them in a primary care house call way. And, which is important to the topic for tonight, we also decided to do hospital geriatrics. We decided to take care of our patients in the hospital. So we did house calls, and we have a team, which I'll talk a little bit about, that's still doing that work till this day. And I made house calls today down in Washington, D.C. But we also want to take care of our patients over time in the hospital and until the end of life. So if our patients joined hospice, for example, George and I and our team would say, we're glad to have the hospice nurses, but we're going to still be their primary care doctor, and we're going to take care of them until the last day of life. That's kind of been my journey, and I have found, and I tell this to the medical students and residents I work with now, that geriatrics is an extraordinary field. I feel like I'm growing and learning as much every day today as I did when I made those house calls in Highlandtown and Dundalk. It's kind of satisfying that I can say that about my career in medicine. Over dinner, someone was telling me, aren't a lot of doctors burnt out or disillusioned? And I said, I think a lot of them may be, but I think geriatricians really find deep meaning in the work that we do. And making visits to the home adds whole extra meaning and level to that. So I'm going to talk today. I'm going to talk for maybe 15, 20 minutes in a framework of what the topic is. And I'm going to actually ask for questions. I don't want this to just be a lecture for 45, 50 minutes. So please feel free to ask questions, hopefully somewhat related to the topic tonight. If we run out of time and all the questions are answered, we can talk about, how to keep our democracy alive, right? But if we get to that. So the topic tonight is From Gravely Ill to Dying. And I borrowed that title from a wonderful paper, which I think I sent it to David. I'm just going to show it to you all, by one of my two main mentors at Hopkins Bayview. His name was Dr. Tom Finucane. And he wrote this paper in 1999, 26 years ago, called How Gravely Ill Becomes Dying. And I recommend it to you all. And some of the topics tonight will be from that paper. And I still read this paper to this day. It's a 2.5-page paper, and I still read it to kind of think about that transition from gravely ill to dying. What do we know about that transition? And what is a mystery? And I still, to this past week, have found things that are really quite a mystery in that transition. I'm going to try to talk a little bit about what we do know. So there's kind of 3 goals. Actually, before I get into the topic, I do want to mention a couple other things about David. He gave a nice story of our friendship, and to this day, Sarah and David and my wife Melissa and I get together for dinner every couple months, and that's kind of one of the highlights of our lives, to share that time together. The first time I met David was 31 years ago. It was on a grassy plaza at the General Theological Seminary in New York City, where this seminary student, who was the kind of Sarah's husband at the time, and I was meeting my wife's best friend husband, so I was kind of excited about that. And we started then, and then David, as he said, officiated our wedding. And I didn't know that he wasn't official yet. So I have to check to see if Melissa and I are truly married. But he gave, wonderful, sermon, and he was the person that we wanted to have join us in marriage, and we've been dear friends ever since. So let's talk about the goals for tonight. One is, I just want to kind of outline the emotional and medical journey that patients, families, and providers go through in this transition. Because the providers, and I'll speak from my team's experience, go through a journey on that, an emotional journey, sometimes in that transition as well, as do patients and families. Talk a little bit about this, what are the signs of imminent death, and how certain can we be that death is actually coming? I'm going to give 3 case studies, if we have time, to talk about 3 different types of end-of-life events. And then I'm going to, again, talk a little about the difference between death at home and death in the hospital, and how that is different. So what's the hardest part? The hardest part, from what I witness for patients and families and for myself, is kind of moving from gravely ill, and fighting death, trying to reverse their illness, which we do, to kind of recognizing that they're terminally ill, truly dying, and seeking peace. So rather than trying to reverse and cure, we recognize that we're not able to do that. And rather than fighting, we're trying to just seek some peace. And it's not one or the other. Sometimes there's a lot of overlap. But that's the hardest part. So what Dr. Finucane, and I've learned this, and George and I have talked this a lot during our careers, why is it so hard? Death is a part of life, and we should kind of all just accept that, and when it comes, shouldn't it be peaceful and beautiful? And for some reason, it's really hard still. And the 2 things that over and over again come up, and they will in the cases I present, there's 2 main reasons why it's really hard. One is, and to Dr. Finucane's words, the deeply held desire to not be dead. Right? And what does that mean? A deeply held desire to not be dead. Well, it means you're going to act differently when you approach that moment. In kind of anticipation, us healthier, walking, talking people, younger people might say, well, I don't want to go through that. I don't want to be on a ventilator. I don't want to have invasive machines. But as another mentor of mine said, the appearance of the bull changes when you enter the ring. And so people have a strong desire not to be dead. What does that mean? That means you're willing to suffer, maybe more, as we approach death because of that desire. People do things that are a little bit surprising. For example, there's lots of literature on this, and we witness this every day or every week. People, for example, are willing to accept intensive toxic chemotherapy for a very small chance of benefit or survival. Why do people do that? There was an extraordinary study, which I often will quote to the residents. It was done at the Hopkins Bayview Geriatric Center. There was a unit there until recently where people who had quadriplegia, totally paralyzed, they cannot move, high cervical quadriplegia, are on ventilators. So with tracheostomy, they couldn't breathe. They're on a ventilator for more than a year. There was about 20, 30 of them during the course of the study. And they did a quality of life study of them. And what percentage of them, so they've been on a ventilator for more than a year, they can't talk, they're bedbound, they're quadriplegic. What percentage of them do you think rated their quality of life excellent or good? Who would say 20%? 50%? Anyone think it was 50%? So people with 50%. What do you think? Anyone want to take a guess? Yeah, 85 or 5? 5% is kind of what you would think about. What do you think? 5%? 80%. All right, so range from 5 to 80, right? So lots of variability. It was 64%. Once you're in the ring and you're on a ventilator and you're totally paralyzed, 64% of them rank their quality of life as good or excellent. Now, there's a selection bias there. These are people who chose to go on a ventilator, right? So the people who didn't choose to go on the ventilator weren't in the survey. But that's pretty remarkable. The other thing that's interesting, you've heard of advanced care plans, advanced directives, living wills, all of those documents, 5 wishes, and the most forms. The states are very restrictive, actually, in what you can decide you want in the future. Like in Maryland, for example, when you fill out that legal state form, you have to you can only say you don't want a ventilator or CPR in the case of terminal illness, an end-stage condition, or persistent vegetative state. So it's very restrictive. You can't say, if I'm frail or in a wheelchair, I don't want to be resuscitated. You can only say it in very restrictive things because people's opinions change once they get to that future state. The other part of advanced care planning is healthcare POA or proxy, right? Someone who will make decisions for you. There's much less restriction on that because that person's going to make the decisions in the moment at the time that you're in that situation. So just another reason why people change their thinking, and so what you can say in those living wills and advance directives are actually pretty restricted. So that's one reason why it's hard to transition. The second reason, again, from this old article and what we learn and witness every day, is the uncertainty in medicine. Doctors are not good at predicting what's going to happen. Our ability to make a prognosis, how long do I have, is notoriously a guessing game. So if you have a desire not to be dead, strong desire, and the doctors can't really tell you what the future holds very easily, then that generates hope, right? Because I'm going to be the ones who are going to succeed. I'm going to be the ones who are going to make it. And there's some really interesting data on this, because terminal is kind of a relatively educated guess until the last few days, how long people are going to live. So that uncertainty plays a big role, at least in my daily life with patients and families. Because it's uncertain, people really struggle with giving up. One study, that's called the support study, found that of patients who had a 6-month prognosis, less than 6 months to live, 47% of them lived more than 6 months. Those who the doctors, these are expert critical care oncologists, really top-notch medical centers around the country. They thought they had 10% of all the patients who had a 10% chance of living 6 months, like really end stage, they're convinced they're going to die within 6 months. 41% were alive after 6 months. So that uncertainty is really hard to kind of say when the end is near. There are some diseases you have more certainty, and some diseases we have less certainty. So the ones we have more certainty about how things are going to go in the next few days or weeks or months, things like metastatic cancer. It's a lot more clear what the future holds for metastatic cancer, depending on the cancer. Multi-organ failure, you may have heard that, but if your heart, your lungs, your kidney, and your brain all are failing, we're pretty good at predicting how people are going to do. But that's a pretty small number of patients that we are really confident about. The less certain diagnoses are really common. Congestive heart failure. People can live much longer than we expect, or they can die suddenly with serious heart disease. Kidney failure. People on dialysis can live a long time, but I have a lot of patients who decide not to go on dialysis. And they go to hospice, and then 9 months later, we decide they graduate from hospice, because they haven't passed away. So kidney failure is often hard to predict. Severe dementia, right? So people have severe dementia have a lot of uncertainty in their prognosis. There was one study that patients who had severe dementia, bedbound, mostly nonverbal, went into hospice, and 3 years later, 30% of them were still alive. I'm saying all this just because the uncertainty of prognosis is what we struggle with as doctors, so we can't give that kind of clear, finite answers to patients and families. So deeply held desire not to be dead, and a lot of uncertainty. And so people kind of oscillate between hope, and maybe I am getting better, and then acceptance. It looks like, I'm terminally ill, and people really struggle between hope and acceptance. I'm going to stop for just a minute, because I'm going to go on to a little bit more medical stuff about imminent death, and then go into my cases. Any questions about that framework that I've talked about so far? Sir?
I'm sorry. Ooh. My experience is particularly with a parent, but um, having a mindset that I'm not dying of anything in particular, but spiritually and emotionally, I'm done. And I want permission to be able to let go.
Yes, that's a wonderful point. So some people talk about euthanasia, and when they ask me as a geriatrician, what do you think of euthanasia? I said, I don't think euthanasia is necessary. Because if you do, as this gentleman just said, if you just allow people to pass naturally, don't go to the hospital. If they're done, you keep them at home. Generally, people will pass away, in kind of a natural, comfortable, dignified way. So I think, and we can keep people comfortable at that stage. So I think listening to the psychological, emotional kind of side of folks is important, but you have to have a doctor or a team that's willing to support you in that, and stay at home and not go to the hospital. There was one other question somewhere over here. Yes, ma'am?
Or I was just wondering if any of your studies included people who had an eternal perspective or the faith factor that was,
It's a great question. The studies that I'm citing weren't necessarily my studies. I mean, a lot of my patient population that actually we take care of in DC are profoundly spiritual, deep faith, and that can go both ways. Sometimes it's they want to transition is the way they talk to me, and they are comfortable with their life as it has been led, and they're at peace, and they're ready to go to heaven or to God, and that really is helpful. Some folks say, life is precious, I'm willing to suffer no matter what, every day is valuable, and God would want me to be in the ICU on a ventilator. Right? So it kind of goes both ways. All right, so I'm going to talk a little bit about imminent death, and it's not going to be too medical. I'm just going to say that, doctors aren't sure, but we do know there are times where I think I can confidently say, I think death is imminent. Usually within 3 or 4 days of death. And the signs of that are, again, multi-organ failure, right? Heart, lungs, kidney, and brain are kind of the 4 major ones. If they're unresponsive mentally and they don't eat or drink at all, you can live 7 to 10 days. If you really stop drinking, you stop eating, or you're unresponsive and you're not able to eat or drink. So then you're pretty sure. If your blood pressure is low and your oxygen is low, that combination is something that isn't sustainable for more than a few days. Agonal breathing, you've heard about it. If they take just very slow, shallow breaths, just a few a minute, that's even in the last couple days. But that's the way you can really know it's imminent. But after that, there's a lot of uncertainty. So there are mysteries about imminent death. And one of my cases, I think I'm going to give some examples of that. I have a lot of patients in our house call program in DC who had repeated recoveries from things that the doctors thought they weren't going to survive. And so the patient, and one patient, she lived with us for 15 years. She was quadriplegic from MS. She came into the hospital, and every time she came to the hospital, she'd go to the ICU, she had pneumonia, and the daughters and the patient would say, we want everything done. And the doctor said, why would you do that? You're terminally ill. And then 3 years later, she would come to the ICU, and the doctor would say, a new set of residents would say, why are you doing this? And 2 years later, literally, she would come to the ICU, and she would be on the ventilator briefly, and then she'd go home. So that's a mystery, because a lot of people don't go through that near as much, and they die much more quickly. One of my cases, which I'm going to talk about, but just a preview, is that there was sometimes people then decide to let go, and they actually die much faster than we think. There's a gentleman this past week I saw in the hospital, and I was talking to him at 2 p.m., and he decided that he didn't want the cardiologist to do anything to him, and at 2 a.m. that night, he had passed. And I'm almost convinced that he had kind of decided, and his spirit said enough, and he didn't want to go home. His wife of 75 years had died a couple months before, and he stopped. So there's a lot of mystery about the timing of this. The last thing about this topic I want to mention, what are the barriers? Because one thing I do feel strongly about is I want to make sure people have peace and comfort when they make this transition. And there are a lot of barriers to attaining peace and comfort. And two of them we've already mentioned, right? This deep desire to kind of fight and not die, that is a barrier to being at peace. The uncertainty can be a barrier, but there are other things that are more difficult. So family dynamics, right? Children disagreeing about what we should do for mom or dad. And then the doctors get caught in the crossfire. Denial that this is real, the denial that people are sick. We had a case in the ICU last week where my colleague sat down in a family meeting and they said, oh, my dad was fine until 3 days ago. And he had all sorts of serious illnesses, but the family was in kind of denial. Religious beliefs we've talked about. Mental incapacity. So if someone doesn't have mental capacity, you can't talk to them, then you have to talk to a family member. And it's always helpful if they've identified a clear family member, but if there's no family member or the family disagrees, you can't ask the patient. And then there's conflict within the family. So these are barriers that our team works to overcome. I'm going to talk about 3 cases. We have, I think we'll have time for all 3 of them. And just notice the ages of these patients. I'm still struck, even as a geriatrician, there's a lot of different types of patients in geriatrics. So the ages of these patients are 97, 84, and 75. And they all approached end of life quite differently. And I think sometimes age does play a role. The first one is Mr. Leon. He's someone I just met 7 days ago. He's a 97-year-old who lived in southern Maryland, a strong, salt-of-the-earth guy, lived by himself on a kind of back side street in his town in southern Maryland. He had neighbors. In fact, he kept his door open 24 hours a day because the neighbors would all bring him food day and night because he wasn't a very good cook. But he would go volunteer at the fire department. He would play cards. He still drove like 1 mile from his house in his village. He had 3 sons. One son had died last August of cancer. His wife had died. Wife of 75 years had died in November. And he had been kind of her caregiver. So he was doing fine until 1 week ago. So a week ago from last Wednesday. And he got really short of breath. He was very tired. And he was restless. He couldn't sleep at night. So he got brought into the hospital, and he was found to have critical aortic stenosis. His heart valve, the main heart valve, barely opened, so blood couldn't get out of his heart. Just a little tiny squirt of blood when his heart would pump. And he was getting short of breath, and he couldn't sleep, and he couldn't lie down. And the cardiologists at my Washington Hospital Center, who are wonderful cardiologists, he transferred in from an outside hospital. He was clear of mind, a delightful guy. The doctors gave him some diuretics, and he felt a little better. And then the next morning, this is day 2, I saw him a second day, he had worsening kidney function. So he was starting to have kidney failure. So heart and kidney, right? Those 2 organs don't kind of, if at least one of them doesn't work, you're kind of in trouble. And so the cardiologist said, well, we got a fix for this. We have this fancy procedure called a TAVR. Some of you may have heard of a TAVR, T-A-V-R. It's a wonderful procedure for older people. You don't have to do open heart surgery. You can put a catheter in their groin, float a new valve up into the heart, snap open the aortic valve, place a whole new beautiful aortic valve in, and the valve works beautifully. And he was 97, and he only really had this heart problem. And they said, let's take you to the ICU because you're not stable on the floor. And his son and he and I were talking in front of one of the cardiologists, and the patient said, I want to go home with hospice. I've had a long life, no procedures for me. And I kind of encouraged him to talk about this in front of the cardiologist so they would hear it directly. So I had 2 serious illness conversations. These are serious illness conversations. They're not necessarily hospice, but we had 2 conversations in front of his son, so his son knew what his dad would want, right? And he respected that. And we changed his goals of care. So right there on the cardiology floor, the cardiologists were a little bit surprised because they have this extraordinary, miraculous procedure they can do. And here was a 97-year-old saying, no, thank you. And I don't know if he would have survived it, but he could have. And so within a couple hours, the the poor PA from cardiology, physician assistant, and the cardiologist, like, well, what do we do now? I mean, he doesn't want what we have to offer. And so I said, well, we'll stop one of his medicines because that was making his blood pressure too low, and we'll give him some morphine if he's short of breath, and we'll arrange home hospice like he asked for. So they start doing that, and one of them called me at 5 p.m. He said, well, how do you order home hospice? Because they're just, the culture in the hospital is, on the subspecialty units in particular, it's not, they think that their role, and they do this a lot in a great way, is to save people. And so they weren't sure how to switch gears. So they switched gears, and he got a little bit of morphine, and then I came in the next morning, and I have a patient list, and his name was gone. And this was a totally intact, empowered, funny gentleman. And I looked up his vital signs, and at like 8 hours or 10 hours after I talked with him and his son and the cardiologist, his heart rate went down to 30, and his blood pressure went down to like 50, and then he just died. And he decided, in a lot of ways, to just go. So that was Mr. Leon. He's 97. The lessons from that are that, you have to listen to the patient, make sure the goals are clear, and you have to kind of give permission. I felt like my job there was almost like a minister. I was there to kind of say, it's okay to not do this fancy cardiology procedure and kind of hold off the invasive procedures. It's okay to give some morphine, and if he wanted to go join his wife. That was kind of a beautiful, kind of short story, right, of how it went for him. Any questions about his case? Yeah.
Wait.
I have had 3 primary breast cancers, and my head of oncology from Hopkins, I said, Dr. Fetting, have you ever heard of anyone, he was a double MD in oncology and psychiatry, have you ever heard of anyone that had 3 primary cancers? He goes, I know of one. And I know I was the one, and my chemotherapy did not work. And I remember when I had to put my dog of 14 years down, and we stood around on a warm blanket, shots, 1 and a second. And I said, why can't I have this option if I have cancer again? I mean, I fought it and all this brave stuff. It doesn't matter. Cancer wins. Cancer has its own mind. And I remember thinking, without getting political, abortion's legal, and all the arguments for, it's my body, my choice, I can't sustain it, I can't afford it. Why isn't that afforded to me? Why is euthanasia or doctor-assisted suicide illegal in Maryland? Well, it's my body. I'm 69 years old. Why can't I decide that's what I want for my body?
I mean, I don't have all I can say is I'm not opposed to it for some patients. I personally don't feel that I have found a situation where I couldn't help someone pass away without an active injection. I can help people die. It doesn't happen like that. It can take a matter of days. No, days. I mean, just to be honest, if you stop eating and drinking, you will pass away in less than 10 days. And I've done that with a couple patients, and it works. It's beautiful, it's peaceful, it's dignified. They're in their home. We have home hospice involved, and I almost feel like it's a public service announcement. You can allow yourself to die peacefully. You just have to stop eating and drinking. And your thirst and hunger goes away. We moisten your mouth with water. People are comfortable, and it's very peaceful. If people are, at the end of their life, and that's what they want to do. Sir.
The issue of quality, I really appreciate your examples and sharing. Both of my parents lived into their late 90s. My dad at 95 recommended a cardiologist to get a pacemaker. My field is gerontology, and I've been working with the elderly throughout my life. I've done 10 years in hospice. shared with my mother and father, I said, this is the dilemma. You two are going to make this decision. But he was having beginnings of dementia, actually not really, more than the beginnings of dementia. And this is what can happen. Your body can live much longer, way beyond your mental capacity. My mother was ready to die. And she was on her 7th pacemaker after many, many years, giving out defective pacemakers, leads, and so forth. And so it was really touching, heartwarming, because my father wasn't ready for his wife, my mother, to pass. And so, this discussion, and the doctors really didn't address, they're in Florida, I'm in Maryland, the doctors really didn't confront and address quality of life and this complexity of choices and trade-offs. And it was difficult and painful to, I just voiced, the trade-offs and dilemmas, and they both agreed that, okay, he's going to get a pacemaker. And it was quite difficult, and in memory care, and very, very difficult when after 90, after 95, hearing from cardiologists, yes, we can get you a pacemaker. And many, many years before that, that wasn't the standard, and that you weren't hearing that. So I was just curious about these, when two people are in their frail years, and these kind of differences, and interacting with the medical team, and having some real in-depth discussions before decisions on implantation and other things. So that kind of thing doesn't happen enough.
I agree. Those conversations are what we call serious illness conversations that a lot of doctors are uncomfortable with, but a lot of doctors are willing to do it, especially if you ask for it. So I'm going to do 2 other cases. I do want to get to these 2. The next patient is a Miss Barbara. She's 84 years old. She's a house call patient of mine and our team in D.C. She has vascular dementia, seizures. She's very frail and weak. She weighs 70 pounds. She's in bed, very thin, bedbound. She lives with a devoted daughter named Marquita. A nephew helps out. They have an aide. Long history with our house call team, and that's important. In 2024, she had 3 hospital admissions, and again, the doctor's like, oh, what are we doing? She's not going to survive, and she survived all 3. Pneumonia, GI bleed, and a stroke. So she's back home, and my nurse practitioner, experienced NP named Nancy, who Dr. Toller knows, and I have conversations over several months, and every time we say, what do you think about home hospice to the daughter? Lovely, devoted daughter. She says, nope. Full code, we want everything, because if we go into hospice, they're going to give up on her. And we don't want to give up on Mom. She feeds her with a syringe. That's the only way she can take food and liquid. Her blood pressure is low. I visited a few weeks ago, and after probably the 5th conversation we had on a house call, she said, okay, but we can start hospice in 1 week. Okay, so I made the referral. And the hospice nurse went out 1 week later on a Friday. The hospice nurse walked into the bedroom, and the patient died. So that daughter carried her mom all the way to the finish line, right? And she was not ready. She felt like she did not want to give up. She had a deeply held desire for her mom not to die and to not give up on her. And so I talked with her afterwards, and she was absolutely at peace. She was grateful to Nancy and our team and that we had been with her. We accompanied her that whole way. We didn't argue with her. We didn't say she was being unreasonable. And she was doing most things out of love. She also didn't want to go back to the hospital because how miserable the ER and the hospital experience was for her and her mom. Her mom didn't get the right seizure meds, and her mom would have seizures like that if she didn't get the right seizure meds. So she had a good instinct to not go to the hospital. So again, a lot of uncertainty, right? She defied a lot of doctors' prognoses, very deep desire to keep mom alive, the burdens of the hospital and the ER, but the trust between our team and the daughter is what allowed her to have a peaceful death at home, because she trusted that we would be there for her, and she ultimately accepted hospice at the final step. But it was a little harder. It took a lot more conversations. It was more painful for me and Nancy, because we could imagine if we did CPR and a ventilator on this little waif of a person, we would break all of her ribs. She would never get off the ventilator, and it would be a nightmare for us to do that to her. So there's a part of us on provider side, like, please don't make us do this. Please don't make us put this poor elderly person through all this, because it's not going to work. It's going to be painful and suffering, but the families are unwilling to let go. The third case is, again, a recent one. This is a Miss Ramona. She's 75, right? So 22 years younger than the first gentleman. She has a disease called sarcoidosis, which is a kind of an inflammatory disease in all organs of the body. It's pretty rare. It causes lung fibrosis, scarring. In her case, she had bad lung failure, heart failure, kidney stones, recurrent sepsis, infection in the bloodstream over the past 2 years. She's bedbound, very skinny and debilitated, has diabetes, has a deep stage 4 pressure ulcer on her bottom, deep into her bone. She had a blood clot in her leg. Her right eye is blind. And she's mentally, though, pretty sharp and pretty with it. Over the last 18 months in Washington, D.C., she had 12 admissions to the hospital in 18 months. And everyone, when she came into the hospital, the doctors could not believe the daughter insisted on putting mom through this. Or that the patient, actually, she was on board. She wanted to go through this. And they kept thinking she would die from one of these sepsis, and she recovered, and she went home with her daughter. 12 admissions in 18 months. The doctors often thought she would pass away, but she does not. She lives with this 24/7, devoted, smart, loving daughter. When she gets home, she enjoys her family visits and her TV shows. We had many conversations about goals of care, which is a really important thing for all of us to know. Goals of care is what the palliative care doctors do, what geriatricians do, what the ICU doctors do, and her goal was to do everything. It wasn't for lack of conversation with her and her daughter. But 2 weeks ago, she came back to the hospital. I happened to be in the hospital that week. And I had known the family. She was in the hospital so much that all 3 of my colleagues and I got to know her and the daughter really well. She's one of our patients at home for one of my colleagues is the primary doctor, so I wasn't her primary doctor. So I saw, hey, Katrina, we're really friendly and we know each other pretty well. How do you think mom's doing? Well, I'd read the chart, and she was having worse kidney failure, right? So remember, lung failure, heart failure, and now she has kidney failure. You can't live with those 3 organs not working. But the patient was still pretty alert. And so I went into the room, and the hospital doctor asked me, could you talk to that daughter? I mean, she's making us maybe think about doing dialysis. Because dialysis would be almost impossible in this patient, but the kidney doctor said, well, I can try it. Do you want me to try dialysis? And so I went to the bedside, talked to the patient and the daughter, and I asked the daughter, I didn't say what I wanted. I said, what do you think about dialysis? Because I said to the patient, you have kidney failure. And the patient looked me in the eye, and she said, so I'm going to die. I said, yeah, I think not imminently, but I think soon. And her daughter, who had been totally in lockstep with mom, said, we don't want to do dialysis. I think it would take her faster if we did dialysis. So she did it in part because she didn't want mom to die from complications of dialysis. And I gave her permission to not do dialysis. I offered gently, well, the alternative would be to go home with hospice. But what does that mean, to go home with hospice? It would mean changing all sorts of things. It would mean she doesn't come back to the hospital. It means we don't do CPR. It means we don't put her on a ventilator. Are you okay with that? Just stay at home and be with family. And with tears in her eyes, The daughter said, "That's what we want." I went to see the patient the next day, and I thought she might not remember the conversation. And I went in to see her, and her daughter wasn't there. I said, "Do you remember what we talked about yesterday?" She goes, "Yeah." I said, "What did we talk about?" She says, "I think I want to go home with hospice." And she remembered. We didn't belabor the point. And then she went home, I think last Thursday. And with hospice and with some morphine, and she was with kidney failure and oxygen. And my partner saw her 2 days ago. Today's Wednesday. He saw her Monday. And I read his note. And he's this young, bright-eyed, wonderful geriatrician named Austin Armstrong. And he was thankful that we did home hospice because it was hard for him to keep seeing her go back and forth to the hospital. And his note was like, she's sitting up in the chair watching TV, she's eating better from her daughter, and her daughter said to me, "I think she might get better." And she might for a little while. But the teaching points of that one is that there's tremendous uncertainty, right? You know, in what happened to her the last year and a half. The trust that was built up by making house calls, by accompanying her for all my colleagues and myself, every time she came in, we didn't judge her. We didn't say you're doing things that are, painful and unnecessary to your mom. We just accompanied her. And that last conversation where I accompanied them, they finally got there. Sometimes they can take 18 months of these conversations. So I'm going to talk, we have 10 minutes left. I'm going to talk a little bit about the difference of death in a hospital and death at home. Death in a hospital, I was thinking about it, and because our service is in the hospital. I'm in the hospital 1 out of every 3 weeks, and we go to the ICU, and I really love it because I get to learn from all the surgeons and the ICU doctors and the specialists, and I'm learning a lot. But we also see our patients die in the hospital. And there's 4 ways, at least, you can die in the hospital. 4 different places and experiences of dying in the hospital. One is in the emergency room. You come in, code blue, right? Cardiac arrest, not breathing, from the field. The ER doctors are, has anybody been watching the movie The Pit? The Pit is a really good, realistic ER show. It is really realistic. And that's what... But they also do some end-of-life stuff as well. But anyway, you're code blue, you get intubated with this tube down your throat, you get IVs, you get CPR, you get electric shocks, you're unconscious. And the goal of that is what's something called ROSC, R-O-S-C. R-O-S-C is return of spontaneous circulation, meaning your heart kind of starts beating on its own. And for a geriatrician, that's often a really sad moment, because that means they're alive, but they've gone through all of this experience and trauma, and they're not going to survive. And then you have a lot more conversations to do. But that's one way to die in the hospital. Another way is in the ICU. You come in and you haven't died, you haven't had a cardiac arrest, but you're in the ICU, you're on the ventilator, you have a tube down your nose, the NG tube, you have central lines, you might have had surgery, you're on these medications called pressors that keep your blood pressure up. You're sedated because it's terrifying to be on a ventilator. And you get antibiotics, perhaps. And usually in 3 to 10 days, it kind of ranges depending on why you're there, but generally in 3 to 10 days, you know whether it's going to work or not. Sometimes you know within 2 or 3 days. Sometimes it takes 10, 14 days to know if you're going to survive the ICU. But then, after 10 or 14 days in the ICU, then you face some decisions. And the decisions, if you're still on the ventilator, is to either have a tracheostomy put in for permanent ventilator with a feeding tube, we call it the trach and peg, combination, that if you don't want to come off the ventilator and your family or you decide you want to stay on the machines, then you get that and you're still alive, but you're on life support indefinitely. And then you may go to a nursing home and try to get off the ventilator that way. But oftentimes, people don't want that. And they decide, we're going to stop, we're going to let go, and people die peacefully in the ICU. They'll switch to hospice care, almost comfort care in the ICU. A third way to pass away in the hospital is on the floor. You're not in the ICU. You're not sick enough to be in the ICU, so you come in, you get IV antibiotics or treatment, whatever it happens to be. You're trying to recover. You treat reversible illness. But you also might be thinking, I'm pretty sick, and we want to not go back to the ICU. So people will do the best they can on the medical floor, but if that doesn't work, my father-in-law actually did this. He said, I'm not going back to the ICU. So do what you can for me on the floor, but if it doesn't work, I'm done. And sometimes that's how people pass away on the floor. The fourth way is, on the floors, everyone in the family and the doctors get together and they decide, we want to just do pure comfort care. We don't want to do any more IVs or tubes down the nose or, blood transfusions. We just want to let go. But they're too unstable or or their family's not able to take them home. And sometimes we have to keep them in the hospital because they wouldn't survive the ambulance ride home. So we keep them in the hospital, and they pass away on the floor in private room. It's kind of like an inpatient hospice mentality. We get them a private room, and we get them morphine or whatever they need, and they pass away peacefully in the hospital. So lots of different ways that people pass away in the hospital. So the environment, though, is medical, right? It's a lot of invasive, usually lines. Patients are often unconscious because of the ER or ICU experience. And there's a lot of restrictions. There's restrictions on food you can eat. There's restrictions on guests you can have. There's restrictions on the environment. So you're in a very artificial medical environment for the end of life. And there's I think, almost by definition, more suffering in the hospital than there is when you pass away at home. So how about if it happens at home? What does it take to have a death at home? Well, someone needs to decide, your provider needs to decide that you're probably terminally ill, that you are terminally ill. And it can be gradual, but there have to be clear goals. The patient, the family, and the providers need to agree. This is kind of what we want to do. And the question that, I think George may have actually taught me this question. The question is, where do you want to be? And if you ask that question, where do you want to be? I find that patients and families, that resonates, and they say, I want to be at home. Or some folks say, I don't want to put that on my family. I don't want to be at home when this happens. But the home has a very different environment. You get support from aides and family and hospice and nurses, house call teams like ours, or primary office doctors. It's more human. It's a lot more time for family. You can eat your favorite foods, like Miss Ramona. You can watch your TV shows. You have physical touch, which is hard to have in the hospital, and you can be awake. So a very different experience in the hospital at home. So we have 5 minutes left. I have some key principles I want to walk through, but before I do that, any other questions? Quite a few. Why don't we go to this side and then here?
Thank you. So I have a question and an observation. It seems like what comes up for me as I hear you talking, that there's this one big question, and that is really what does it mean to be alive? What does it mean to be, what's life beyond just breathing? And it reminds me, I had an aunt that died about 10 years ago of kidney failure. And she knew that she was in kidney failure. And she went to all the videos where they talked about dialysis. She went to have the consultation for the port, but she never, ever did dialysis. And when she died, it was because of kidney failure. And for a long time, I said, Annie, when are we gonna, go? When are you gonna do this? She said, no, it takes up too much time. I don't want to live like that. I need to be able to do the things that I want to do on my, and one day she just died. One day she just died because she didn't want to be tied to dialysis for a while. I was angry because I felt like she could still be here. But then after a while, I made peace with it because I understood that she did it the way that she wanted to do it. And it was about what living meant to her.
And it's different for different people, right? For her, that was just the exact right thing to do. Let me take a couple more questions, and in the interest of time, I want to also finish with a couple of points. So why don't we, right here.
Well, I'd like to say your patients are very lucky to have you as a geriatrician, and I'm wondering if there's anything like that in the Baltimore area. I never knew about geriatricians and a team that would come in. That's my one question. But the other is, what determines whether you go to a facility like Gilchrist to die in a hospice situation or die at home? Is it up to you?
It's a great question. So 2 questions. The first is about geriatricians and teams. So the short answer is there are several in Baltimore. One is at Good Sam, which actually George Toller and the MedStar run a good geriatrics program. George is retiring very soon, almost imminently, but there's a team at Good Sam. There's also a very good geriatrics team at Hopkins Bayview. There's about 12, 15 geriatricians. They have a house call program there, and they have a whole full array of geriatric services. So the second question is about hospice and where you go. Gilchrist is an inpatient hospice. To be in an inpatient hospice, by Medicare rules, you have to have active symptoms of actively dying. So usually it's the last week or 2 of life. And generally, if you live more than a week or 2, you have to find another place to live. You can't stay in an inpatient hospice much longer than that unless you have a lot of symptoms that require care. So 95% of hospice is done at home. One more question?
I'm a critical care chaplain at Hopkins, and I would just say I think it's important to mention that even when we do a terminal extubation or whatever, death is still a highly variable event.
Yeah.
I've seen many people who have the ventilator removed and are still in the hospital, I mean many, 2 weeks later, who haven't died. So what your point about, we really don't know when anyone's going to die. I say the only way I can say with certainty is when I got paged to the ED and there's a guy with 24 gunshot wounds to the chest, right? And then I can say with certainty, yep, that's what's going to happen. But other than that, there really is no way to do it. And the other thing I think it's also important to note is that at least at Johns Hopkins, there's a lot of patients who don't want to go home to die. And as you're well aware, there's a lot of control in the hospital, and especially control of symptoms. And that provides people with some comfort. So I think it's really important to be sensitive to that notion. I think that a priori we have these notions that, yep, everybody should die at home, and not everybody really wants to.
And the hospital can provide, especially for people with a lot of symptoms and are very ill, hospital can provide things that it's hard to do at home. So that's where I sometimes will have people go to the inpatient hospice if they have a lot of complicated symptoms. So again, I want to end on time. One of my mentors always said that one of the key principle in life is sotiot, S-O-T-E-O-T. Anyone know what that means? S-O-T-E-O-T is one of my favorite rules of life. Start on time, end on time. And so my team in DC gets a little frustrated with me, but that's what I try to do. I'm going to try to do it here. So the key principles to kind of sum up is it's really important to be really clear about your goals of care and have someone you trust. It may not be your child or spouse even, but someone you trust who knows what your wishes are, and that's called the healthcare POA. I think the healthcare POA is more important than living wills and advance directives, because a lot of times people change their mind, or you can't write everything down that's going to happen, in the future. So having a clear, trusted person about knowing what matters most to you. Like my wife, Melissa, knows that what matters most to me is that when I'm in my last days, I'm going to be out in the back porch with her, splitting one beer. That's what we do on Saturday night. And so we're going to, cook, and I'm going to split half a beer with my wife. That's what I want, where I want to be when I die. And then for the providers, the key principle is to accompany and kind of guide the patient and their family, not to try to make them do what you think they should do, but have an ongoing relationship, a trust over the long term with lots of serious illness conversations, and be aware of their experience. I think of Miss Ramona and her daughter, and she went to the hospital 12 times in 18 months, but she thought it was all worth it. So really, I like to ask, what is your understanding of your illness? Who should we involve? And then continuous review of the burdens and the benefits of treatment. It changes, right? You may want to do 12 admissions to the hospital, but that 13th admission, the burden is too much. You have to keep having that conversation. So that trust, I find, is the most core ingredient in kind of having this go well. And then we give permission to forego invasive therapy. I just want to highlight some of the things that my patients and you could forego if you decide you want to forego them. You know, ventilator, a PEG. Haven't you heard of the word PEG? It's a feeding tube, right? A permanent feeding tube. If you're not awake or you can't swallow or eat, we can put a feeding tube in your stomach and you can live with that. Dialysis, CPR, transfusions, antibiotics, hospital care. These are all things you can decide whether you want them or not. But I think the part of the role as we transition from gravely ill to dying is understanding which of those we may want to forego. I'm going to just close by saying, you know, being in geriatrics, I've learned, I told you these stories of these past 2 weeks. It continues to be extraordinarily rewarding, and the most sacred part of my work is actually the conversations that I have with patients and families, and being with them all the way to the end. And the highlight of my year so far is that one of my patients who lived 3 years longer than, she was 92, she lived 3 years longer than all the other doctors thought possible. But we hung in there with the family, and then a few days after she died, of home hospice with the same nurse practitioner who hung in there with this other patient, 4 or 5 talks, and the family finally said, okay, we'll let grandma stay at home. They invited me to give her eulogy at a big church in PG County. And I went there, took a couple hours, and I was able to give a eulogy, and I saw kind of how important, and this reminds me of the title of your series, Mortality as Medicine. And her mortality, even the act of dying, was really therapeutic for her family, her church, but it was also for me as well. Thanks for your attention.